Sugammadex, reading from Stoelting 6th edition. Sugammadex is selective relaxer binding agent. So it selectively binds to steroidal NMBDs. Affinity is highest for rock, then wick, then pan, in the ratio of 1:1. So it is a cyclodextrin. It is a donut shaped. It has hydrophobic inside and hydrophilic outside, made of polar hydroxyl group. So it captures NMBDs in their core. You can see it in this diagram, and it binds very strongly with them in 1:1 ratio. We know it can't bind covalently, so all the other forces like van der Waals, hydrogen bonds, and hydrophobic interactions, by these it captures the rock, wick, or pan. Interesting thing is that the reversal is not dependent on depth of neuromuscular blockade. It's just capturing it, so it has nothing to do with depth. We will contrast this with neo later on when we will read the notes. Pharmacokinetics, it is biologically inactive, so it has no effect on the body. It is just capturing agent. It is not metabolized. It is eliminated through urine. And dialysis is also ineffective in removing Sugammadex and Rocuronium. Only thing is that because it is excreted through urine, it is contraindicated when GFR is less than 30. But this is a contraindication based on not disease. It is just because of lack of safety data. If we inject Sugama in these people, it will get deposited, and we don't know what will happen. Reticular endothelial system might capture it, and it will stay there for long. It is contrasted with rock. Rock has 75% of biliary excretion, and renal is just 25, versus Sugama it is 100% urinary excretion. How do we use it? Pharmacodynamics. When train of 4 ratio is more than or equal to 0.9, Sugammadex reverses within 3 minutes. And Sugammadex acts in plasma, not at neuromuscular junction. We know that neostigmine acts at neuromuscular junction. It increases the acetylcholine. Here it captures the steroidal NMBDs in plasma, and then it creates a reverse gradient, and from neuromuscular junction the NMBDs move into plasma. Dose, there are 3 doses, 2, 4, and 16. Shallow block is needed. Shallow block needs 2 mg. When train of 4 count is at least 2, then reversal is in 3 minutes. Deeper level blocks means like only post tetanic twitches are there, then dose has to be 4. And if we have to immediately reverse the Rocuronium, it has dose of 16. So here it is interestingly said that it reverses the block faster than that would have been. Time is less than the recovery of succinylcholine. So if we give succinylcholine for RSI, the time it will take to fade its effect by pseudocholinesterase, we can reverse rock in less time than the needed for succinylcholine. But still this cannot be relied upon in CI/CV conditions. Therefore, it is not recommended to use in conditions where there is difficult or anticipated intubation. Here it has been shown by graph. After administration of Sugammadex, block is getting reversed, and scoline we can see it takes longer time to come back to spontaneous ventilation. So graph is recovery to T1 of 90 degree. Rocuronium needs 4 minutes 47 seconds, and scoline needs 9 minutes 23 seconds. And still in obese people it is highly risky. It is BMI comparison done dosage wise. So we know it is binding agent for aminosteroid groups, so it is ineffective against choline, benzyl isophenolium NMBDs like MEVA, ATRA, and cis-ATRA, because it can't form complexes. And if after usage of Sugammadex, if we again have to paralyze the patient, we have to use then benzyl isoquinone NMBDs, atra, miva or cisatra or scoline. We can use rock or wake. It is mentioned in the leaflet. We can use, but we will read in the notes that thing. Because it binds to amino steroid compounds, and oral contraceptives are also steroid, so Sugammadex can bind and inhibit oral contraceptives, and so we have to use another contraceptive technique for 7 days. Adverse effects mentioned is anaphylaxis and bradycardia. It is rare. It is frequency is noted same as the rock, so it is not a common side effect, and it can be handled with atropine. It can cause arrhythmias including bradycardia and asystole, and it is mentioned that typically they are transient. So let's have a look at the notes. These notes are made from Stoelting, and also the leaflet that comes with the drug. Sugammadex comes in 100 mg in 2 cc or 5 cc packages. So if we use 1 cc, it will be good enough for shallow block. 2 cc if we use, it will be good for deep block, and 10 cc we will need for immediate reversal, like 2, 4 and 16 in this way. It has to be given by bolus in 10 seconds. We don't have to give it slowly. If we have diluted Sugama, we can use it for 2 days. Sugama, the long form is sugar, SU, then gamma, gamma, and dex for cyclodextrin. It is named as ideal reversal agent because it has no side effects, no metabolism. It completely reverses. There is no residual action, so there is no fear of residual action. There are no adverse drug reaction. It is inactive, not metabolized, pass through kidneys. Only caution is GFR less than 30. Sugama and rock are not removed by dialysis. We have already read this. Contraindication, there is no data, therefore we don't use it in kidney diseases less than 2 years and pregnant women. Against Sugammadex, rock is cleared 3/4 by liver and 1/4 by kidneys. It is a binder. It can't bind covalently, so it is binding by van der Waals hydrogen phobic bond. It encapsulates the amino steroids. Affinity is rock, wake, and pan is very less. OCP failure can occur. 1:1 is the ratio. It binds in plasma and not neuromuscular junction. You can see the contrast to neostigmine. Neostigmine depends on depth of the block. It acts at NMJ. It takes 12 minutes, and it needs glyco also. So when we give Sugama, we don't need glyco. And the dosage are 2, 4 and 16. Recovery is faster than scoline spontaneous recovery, but still we can't rely it on CICO conditions. We have to use scoline only. In obese, dose is based on total body weight. There is no max dose limit because there is no adverse drug reaction seen even at 96 mg per kg dose. We can use rock after reversal by Sugama, but if we have to give immediately after 5 minutes, then we have to use 1.2 dose. After 4 hours, we can use 0.6 dose or 0.1 wake dose. And in mild to moderate kidney disease, we have to wait till 24 hours because it will take it to clear drug that much of time. It doesn't bind with scoline and benzyl isoquinone like miva and atra. Therefore, if we have to reparalyze after Sugama, we can use these drugs. So thank you.